Alright, now let's talk about loop diuretics. Well, loop diuretic, we have the furosemide, the bumetanide, and torsemide. The mechanism is, again, these are again sulfonamide, meaning can have an allergy reaction. Loop diuretics. What is the mechanism of them? They inhibit the co-transport system of sodium, potassium, and 2-chloride co-transport, which is here. So whatever it is, sodium chloride co-transport. They inhibit this channel at the thick ascending limb loop of Henle. Abolish hypertonicity of medulla, preventing the concentration of urine. It abolishes the hypertonicity of medulla, prevents the concentration of the urine. It is associated with increase in PGE, which is the prostaglandin, which leads to vasodilatory effect on afferent arterioles, and it is inhibited by NSAID. I mean, prostaglandins are inhibited by NSAIDs. And so this is its effect that can be utilized for its hypertensive use. In hypertension, we use loop diuretic. Why? What's the mechanism of loop diuretic? That it relieves the hypertension. It causes vasodilation by increasing the prostaglandins. NSAIDs, on the other hand, would inhibit those prostaglandins, so you can inhibit the or you can inhibit this effect by giving NSAID. And also, it causes increase in calcium excretion. Loop lose calcium. How does it do that? For that, we have to look at, or maybe we don't, since we don't have anything here, so let's just draw it. So here's the, let me just actually draw it here in an open area. So we have a loop diuretic that is here. We have the sodium, the chloride, the potassium, and 2-chloride co-transport, meaning all of them are going in co-transport. And we have this channel on the other hand, in which you have this chloride, potassium, and sodium channel. So if you recall, intracellularly we have lots of potassium in intracellular, right? So what happens is, normally that potassium that we have intracellularly, and we are also reabsorbing all of the potassium here and also getting potassium from there. All of the potassium comes into a cell. Now what happens is it leaks, because it's so much potassium now that it leaks out. It leaks out and causes, and potassium is a positive ion, so it causes positivity in all of the lumen. And remember, this is all urine, okay? And this is all blood. And this is the cell, the tubular cell, that is doing the actual transport. So that potassium, let me change color, so it's, that potassium leaks out and causes positivity on the which surface? On the luminal membrane. It causes positivity, that potential gradient. Now this gradient, what happens now, that, as you know, the two positive ions the positive charge, they repel each other. So we have the magnesium, the calcium, all are positive charge. So these positive, they're going to repel each other. So now it causes a paracellular transport, meaning between the cells, meaning between two cells, paracellular transport of magnesium and calcium. Magnesium and calcium, through paracellular transport, they are going to get reabsorbed in the blood. All due to the fact that we have positive potential on the luminal membrane, due to the fact that the potassium leaked out causes this positive potential. Okay, so that's all normal. Now let's throw in loop diuretic. Now the loop diuretic, let me just say loop diuretic as this pen in blue. Loop diuretic is going to block this channel, which is a sodium chloride potassium cotransport channel. Once you block this channel, now you are not getting this now you're not getting even the sodium, the potassium, the chloride. So all three are going to go out in urine, that's for sure. Now next thing is, because you're not getting potassium, so not a lot of potassium is being built up in the cell. That means it's not going to leak out. When it doesn't leak out, you don't have any positive potential. When you don't have any positive potential, you cannot reabsorb your magnesium, the calcium, through paracellular transport. When you cannot absorb that, all of them are going in urine. So you have hypo of every single electrolyte when you give loop diuretic. So that's the mechanism of action. Let's go back and read. Clinical uses, we can give it in an edematous state. Example, HF, heart failure, cirrhosis, nephrotic syndrome, pulmonary edema, hypertension, hypercalcemia because it's going to lose that calcium. Adverse effect is autotoxicity, hypokalemia. Now look at the adverse effects. Hypokalemia, hypomagnesemia, magnesium was going out, potassium was going out, dehydration, allergic reaction due to sulfa, metabolic alkalosis, and nephritic interstitial and gout. Now remember, although we said that the sodium, the potassium, the chloride, and also the magnesium and also the calcium are going out, but remember, we have when it comes into the collecting tubules, we have sodium that's going to get reabsorbed, and that's why we don't have hyponatremia, if you look. Okay, I hope it makes sense. Because then later on we will see how the collecting tubule reabsorbs whatever the sodium is left over. Okay, so that's what we have for furosemide. For loop diuretic, and this these loop diuretics we have ethacrynic acid, which is let me erase this and talk about ethacrynic acid. So in this loop diuretics, we have a drug called ethacrynic acid. This is the ethacrynic acid, which is non-sulfonamide, meaning it's not going to give you sulfa allergy reaction. This is the only diuretic which is not going to give you any allergic reaction, because this is a non-sulfa inhibitor of the cotransport system. Does the same mechanism of action. But the problem is it's going to cause more autotoxicity, and sometimes irreversible autotoxicity, while all the rest of the loops did cause autotoxicity, but this is more like reversible autotoxicity. So keep that in mind. If there's some patient with a sulfa allergy, you're not giving any diuretic, but you can give ethacrynic acid, but again at the cost of what? More autotoxicity. So that's pretty much all we have for loop diuretics.